Hey everyone, this is your Nandini ma'am, and we are going to continue with our audio reading of Chapter 2 of Human Anatomy, Volume 1, and we'll continue from the bone radius. So let's get started. The radius is the lateral bone of the forearm and is homologous with the tibia of the lower limb. It has an upper rounded end, a lower broad end with a styloid process, and a shaft. Site determination. Number 1. Upper end is having disc-shaped head, a narrow neck, while lower end is expanded with a styloid process. Close to neck, it presents a radial tuberosity. At the lower end, the anterior surface is in the form of thick, prominent ridge, while the posterior surface presents four grooves for the extensor tendons. Number 3. Lower end presents a tubercle on the posterior surface called as dorsal tubercle of Lister. Number 4. The sharpest border of the shaft is the medial border. Features. Upper end. Number 1. The head is disc-shaped and is covered with hyaline cartilage. Figure 2.19. It has a superior concave surface which articulates with the capitulum of the humerus at the elbow joint. The circumference of the head is also articular. It fits into a socket formed by the radial notch of the ulna and the annular ligament, thus forming the superior radio-ulnar joint. Number 2. The neck is enclosed by the narrow lower margin of the annular ligament. The head and neck are free from capsular attachment and can rotate freely within the socket. Number 3. The radial tuberosity lies just below the medial part of the neck. It has a rough posterior part and a smooth anterior part. Shaft. It has three borders and three surfaces. Figure 2.20. Borders. Number 1. The anterior border extends from the anterior margin of the radial tuberosity down close to the styloid process. It is oblique in the upper half of the shaft and vertical in the lower half. The lowest part is sharp and crest-like. The oblique part is called the anterior oblique line, figure 2.19. Number 2. The posterior border is the mirror image of the anterior border, but is clearly defined only in its middle one-third. The upper oblique part is known as the posterior oblique line, figure 2.20. Number 3. The medial or interosseous border is the sharpest of the three borders. It extends from the radial tuberosity above to the posterior margin of the ulnar notch below. The interosseous membrane is attached to its lower three-fourths, figure 2.21a. In its lower part, it forms the posterior margin of an elongated triangular area, figure 2.22. Surfaces. Number 1. The anterior surface lies between the anterior and interosseous borders. A nutrient foramen opens in its upper part and is directed upwards. The nutrient artery is a branch of the anterior interosseous artery, figure 2.19. Number 2. The posterior surface lies between the posterior and interosseous borders. Number 3. The lateral surface lies between the anterior and posterior borders. It shows a roughened area in its middle part. Lower end. The lower end is the widest part of the bone. It has 5 surfaces. Number 1. The anterior surface is in the form of a thick, prominent ridge. The radial artery is palpated against this surface. Number 2. The posterior surface presents 4 grooves for the extensor tendons. The dorsal tubercle of Lister lies lateral to an oblique groove, figure 2.20. Number 3. The medial surface is occupied by the ulnar notch for the head of the ulna, figure 2.20. Number 4. The lateral surface is prolonged downwards to form the styloid process, figure 2.20. Number 5. The inferior surface bears a triangular area for the scaphoid bone and a medial quadrangular area for the lunate bone. This surface takes part in forming the wrist joint. See figure 10.24. Attachments. Number 1. The biceps. Brachii is inserted into the rough posterior part of the radial tuberosity. The anterior part of the radial tuberosity is covered by a bursa, figures 2.22 and 8.4. Number 2. The supinator is inserted into the upper part of the lateral surface, figure 2.23. Number 3. The pronator teres is inserted into the middle of the lateral surface, figure 2.22. Number 4. The brachioradialis is inserted into the lowest part of the lateral surface just above the styloid process, figure 2.22. Number 5. The radial head of the flexor digitorum superficialis takes origin from the anterior oblique line and the upper part of anterior border, figure 2.22. Number 6. The flexor pollicis longus takes origin from the upper two-thirds of the anterior surface, figure 2.22. The pronator quadratus is inserted into the lower part of the anterior surface and into the triangular area on the medial side of the lower end. The radial artery is palpated for radial pulse as it lies on the pronator quadratus medial to the sharp anterior border of radius, lateral to the tendon of flexor carpi radialis. Number 8. The abductor pollicis longus and the extensor pollicis brevis arise from the posterior surface, figure 2.23. Number 9. The quadrate ligament is attached to the medial part of the neck. Number 10. The oblique cord is attached on the medial side just below the radial tuberosity, figure 2.22. Number 11. The articular capsule of the wrist joint is attached to the anterior and posterior margins of the inferior articular surface. Number 12. The articular disc of the inferior radio-ulnar joint is attached to the lower border of the ulnar notch. See figure 10.24. Number 13. The extensor retinaculum is attached to the lower part of the sharp anterior border. See figure 9.52b. Number 14. The interosseous membrane is attached to the lower 3/4 of the interosseous border. Number 15. The first groove between sharp crest-like lowest part of anterior border and styloid process gives passage to abductor pollicis longus and extensor pollicis brevis, figure 2.21b. Number 16. The second groove between styloid process and dorsal tubercle gives way to extensor carpi radialis longus and extensor carpi radialis brevis tendons. Number 17. The third oblique groove medial to dorsal tubercle gives passage to extensor pollicis longus tendon. Number 18. The fourth groove on the medial aspect gives passage to tendons of extensor digitorum, extensor indicis, posterior interosseous nerve, and anterior interosseous artery. Number 19. In addition, at the junction of lower ends of radius and ulna, the fifth groove gives passage to the tendon of extensor digiti minimi. Number 20. Lastly, in relation to ulna, between its head and styloid process is the sixth groove, traversed by the tendon of extensor carpi ulnaris, figure 2.21b. These are 6 compartments or grooves under extensor retinaculum of wrist. 4 are in relation to radius, 5th at the junction of radius and ulna, and 6th on the ulna itself between its head and styloid process, figure 2.21b. Ossification. The shaft of radius ossifies from a primary center which appears during the 8th week of development. The lower end ossifies from a secondary center which appears during the first year and fuses with shaft at 20th year. It is the growing end of the bone. The upper end, head, ossifies from a secondary center which appears during the 4th year and fuses with shaft at 18th year. Table 2.1. Clinical anatomy. The radius commonly gets fractured about 2 cm above its lower end, collisus fracture. This fracture is caused by a fall on the outstretched hand, figure 2.24a. The distal fragment is displaced upwards and backwards, and the radial styloid process comes to lie proximal to the ulnar styloid process. It normally lies distal to the ulnar styloid process. If the distal fragment gets displaced anteriorly, it is called Smith's fracture. Figure 2.24b. A sudden powerful jerk on the hand of a child may dislodge the head of the radius from the grip of the annular ligament. This is known as subluxation of the head of the radius, pulled elbow, and the head can normally be felt in a hollow behind the lateral epicondyle of the humerus. Ulna. The ulna is the medial bone of the forearm and is homologous with the fibula of the lower limb. It has an upper end with two processes, a shaft, and a narrow rounded lower end. Side determination. Number 1. The upper end is hook-like with its concavity directed forwards. Number 2. The lateral border of the shaft is sharp and crest-like. Number 3. Pointed styloid process lies posterior medial to the rounded head of ulna at its lower end. Features. Upper end. The upper end presents the olecranon and coronoid processes and the trochlear and radial notches. Figure 2.19. Number 1. The olecranon process projects upwards from the shaft. It has superior, anterior, posterior, medial, and lateral surfaces. The anterior surface is articular. It forms the upper part of the trochlear notch. The posterior surface forms a triangular subcutaneous area which is separated from the skin by a bursa. Inferiorly, it is continuous with the posterior border of the shaft of the ulna. Its upper part forms the point of the elbow, figure 2.20. The medial surface is continuous inferiorly with the medial surface of the shaft. The lateral surface is smooth, continue as posterior surface of shaft. The superior surface in its posterior part shows a roughened area. The coronoid process projects forwards from the shaft just below the olecranon process and has four surfaces, namely superior, anterior, medial, and lateral. The superior surface forms the lower part of the trochlear notch. The anterior surface is triangular and rough. Its lower corner forms the ulnar tuberosity. The upper part of its lateral surface is marked by the radial notch for the head of the radius. The annular ligament is attached to the anterior and posterior margins of the notch. The lower part of the lateral surface forms a depressed area to accommodate the radial tuberosity. It is limited behind a ridge called the supinator crest. Medial surface is continuous with the medial surface of the shaft. Number 3. The trochlear notch forms an articular surface that articulates with the trochlea of the humerus to form the elbow joint. Number 4. The radial notch articulates with the head of the radius to form the superior radio-ulnar joint, figure 2.26. Shaft. The shaft has three borders and three surfaces, figure 2.21. Borders. Number 1, the introitious or lateral border is the sharpest in its middle two-thirds. Inferiorly, it can be traced to the lateral side of the head. Superiorly, it is continuous with the supinator crest. Number 2, the anterior border is thick and rounded. It begins above on the medial surface of the ulnar tuberosity, passes backwards in its lower one-third, and terminates at the medial side of the styloid process. Number 3, the posterior border is subcutaneous. It begins above at the apex of the triangular subcutaneous area at the back of the olecranon process and terminates at the base of the styloid process, figure 2.20. Surfaces. Number 1. The anterior surface lies between the anterior and the introitious borders. A nutrient foramen is seen on the upper part of this surface. It is directed upwards. The nutrient artery is derived from the anterior introitious artery, figure 2.16. Number 2. The medial surface lies between the anterior and posterior borders, figure 2.19. Number 3. The posterior surface lies between the posterior and introitious borders. It is subdivided into three areas by two lines. An oblique line divides it into upper and lower parts. The lower part is further divided by a vertical line into a medial and a lateral area. Lower end. The lower end is made up of the head and the styloid process. The head articulates with the ulnar notch of the radius to form the inferior radio-ulnar joint. It is separated from the wrist joint by the articular disc, see figure 10.24. Ulnar artery and nerve lie on the anterior aspect of head of ulna. The styloid process projects downwards from posterior medial side of lower end of the ulna. Posteriorly, between the head and the styloid process, there is a groove for the tendon of extensor carpi ulnaris. Figure 2.21b. Attachments. The triceps brachii is inserted into the rough posterior part of the superior surface of the olecranon process. Figure 2.23. The anterior part of the surface is covered by a bursa. Number 2. The brachialis is inserted into the anterior surface of the coronoid process, including the ulnar tuberosity. Figure 2.22. Number 3. The supinator arises from the supinator crest and from the triangular area in front of the crest. Figure 2.22. Number 4. The ulnar head of the pronator of the flexor digitorum superficialis arises from a tubercle at the upper end of the medial margin of the coronoid process. I'm repeating number 4 point. The ulnar head of the flexor digitorum superficialis arises from a tubercle at the upper end of the medial margin of the coronoid process. Number 5. The ulnar head of the pronator teres arises from the medial margin of the coronoid process. Number 6. The flexor digitorum profundus arises from the upper 3/4 of the anterior and medial surfaces of the shaft, the medial surfaces of the coronoid and olecranon processes, the posterior border of the shaft through an aponeurosis, which also gives origin to the flexor carpi ulnaris and extensor carpi ulnaris. Number 7. The pronator quadratus takes origin from the oblique ridge on the lower part of the anterior surface. Figure 2.22. Number 8. The flexor carpi ulnaris arises from the medial side of the olecranon process and from the posterior border. Number 9. The extensor carpi ulnaris arises from the posterior border. Figure 2.23. Number 10. The enconeus is inserted into the lateral aspect of the olecranon process and the upper 1/4 of the posterior surface of the shaft. Figure 2.23. Number 11. The lateral part of the posterior surface gives origin from above downwards to the abductor pollicis longus, the extensor pollicis longus, and the extensor indicis. Number 12. The interosseous membrane is attached to the interosseous border. Number 13. The oblique cord is attached to the ulnar tuberosity. Number 14. The capsular ligament of the elbow joint is attached to the margins of the trochlear notch, that is, to the coronoid and olecranon processes. Figure 2.22. Number 15. The annular ligament of the superior radio-ulnar joint is attached to the two margins of the radial notch of ulna. Figure 2.26. 16. The ulnar collateral ligament of the wrist is attached to the styloid process. Number 17. The articular disc of the inferior radio-ulnar joint is attached by its apex to a small rough area just lateral to the styloid process. See figure 10.24. Ossification. The shaft and most of the upper end of ulna ossify from a primary center which appears during the 8th week of development. The superior part of the olecranon process ossifies from a secondary center which appears during the 10th year. It forms a scale-like epiphysis which joins the rest of the bone by 16th year. The lower end ossifies from a secondary center which appears during the 5th year and joins with the shaft by 18th year. This is the growing end of the bone. Table 2.1. Clinical anatomy. The ulna is the stabilizing bone of the forearm with its trochlear notch gripping the lower end of the humerus. On this foundation, the radius can pronate and supinate for efficient working of the upper limb. The shaft of the ulna may fracture either alone or along with that of the radius. Cross union between the radius and ulna must be prevented to preserve pronation and supination of the hand. Dislocation of the elbow is produced by a fall on the outstretched hand with the elbow slightly flexed. The olecranon process shifts posteriorly and the elbow is fixed in slight flexion. Normally, in an extended elbow, the tip of the olecranon process lies in a horizontal line with the two epicondyles of the humerus, and in the flexed elbow, the three bony points form an equilateral triangle. These relations are disturbed in dislocation of the elbow. Fracture of the olecranon process is common and is caused by a fall on the point of the elbow. Fracture of the coronoid process is uncommon and usually accompanies dislocation of the elbow. Madelung's deformity is dorsal subluxation of the lower end of the ulna due to retarded growth of the lower end of the radius, figure 2.27. Ossification of humerus, radius, and ulna. Law of ossification. In long bones possessing epiphysis at both their ends, the epiphysis of that end which appears first is last to join with the shaft. As a corollary, epiphysis which appears last is first to join. These ends of long bones, which unite last with the shaft, are designated as growing end of the bone. In case of long bones of the upper limb, growing ends are at shoulder and wrist joints. This implies that the upper end of humerus and lower ends of both radius and ulna are growing ends, and each will, therefore, unite with its shaft at a later period than its corresponding other ends. The direction of the nutrient foramen in these bones, as a rule, is opposite to the growing end. The time of appearance and time of fusion, either of various parts at one end or with the shaft, are given in table 2.1. Importance of capsular attachments and epiphyseal lines. Metaphysis is the epiphyseal end of the diaphysis. It is an actively growing part of the bone with rich blood supply. Infections in this part of the bone are most common in the young age. The epiphyseal line is the line of union of metaphysis with the epiphysis. At the end of the bone, besides the epiphyseal line, is the attachment of the capsule of the respective joints. So, infection in the joint may affect the metaphysis of the bone if it is partly or completely inside the joint capsule. As a corollary, the disease of the metaphysis, if inside a joint, may affect the joint. So, it is worthwhile to know the intimate relation of the capsular attachment and the epiphyseal line at the ends of the humeral, radial, and ulnar bones as shown in figure 2.2. Relation of capsular attachments and epiphyseal lines. Name of the bone and part, capsular attachment, epiphyseal line, metaphysis. Humerus, upper end. Laterally to the anatomical neck, medially 2 cm above or below the shaft and deficient at bicipital groove. At the lowest part of articular surface of the head. Metaphysis is partly intracapsular. Humerus, lower end. Follows the margins of radial and coronoid fossae and the olecranon fossa. Both epicondyles are extracapsular. A horizontal line at the level of lateral epicondyle, medial epicondyle owns a separate epiphyseal line. Metaphysis is partly intracapsular. Radius, upper end. Attached to the neck of the radius. The head forms the epiphysis. Metaphysis is intracapsular. Radius, lower end. Close to the articular margin all around. Horizontal line at the level of the upper part of the ulnar notch. Metaphysis is completely extracapsular. Ulna, upper end. Near the articular surface of ulna, scale-like epiphysis on the upper surface of olecranon process. Metaphysis and part of diaphysis are related to capsular line. The epiphysis is extracapsular. Ulna, lower end. Around the head of ulna. Horizontal line at the level of articulating surface of radius. Metaphysis is partly intracapsular. Clinical anatomy. Relation of capsular attachments and epiphyseal lines. If epiphyseal line, that is site of union of epiphysis and metaphyseal end of diaphysis, is intracapsular, the infections of the joints are likely to affect the metaphysis, the actively growing part of the bone, especially in young age. So this was your part 2. See you soon with part 3.